In next 10 to 15 minutes, I'm going to talk about 2016 updates to WHO classification of CNS tumors. All prior classifications are based on histological morphology and level of differentiation. For the first time ever, molecular parameters were taken into consideration in classifying CNS tumors. There are two ways to identify genetic signature of brain tumor. One is direct interrogation of mutated DNA, and second one is to detect protein products, that is oncometabolites of specific oncogenic mutations. In this classification, we are having bunch of removals, additions and changes. First, we will see what are the terms that are removed. Those include gliomatosis cerebri, fibrillary astrocytoma, protoplasmic astrocytoma, and peanut. These terms no longer exist. But we can say that is gliomatosis cerebri previously considered as distinct entity, now considered as growth pattern in any form of infiltrating glioma. Any form of infiltrating glioma can show gliomatosis cerebri pattern, most commonly seen in anaplastic astrocytoma. So gliomatosis cerebri pattern we can give in report, but we cannot give it as diagnosis. Then coming to fibrillary astrocytoma previously used to describe infiltrating gliomas or infiltrating astrocytomas, no longer in use now. Then coming to protoplasmic astrocytoma, previously used to describe oligodendroglioma, now not in use. Then primitive neuroectodermal tumor is the most important one. All the tumors which comes under peanut are considered now as separate entities, not grouped under peanut, as this term is no longer in use. Then coming to additions, what are the additions? Diffuse midline gliomas, ependymoma renal fusion positive, multinodular vacuolated tumor of cerebrum, diffuse leptomeningeal glioneuronal tumors. These are the new additions in WHO 2016 classification. Then coming to changes, this is the most important thing which we need to remember. What got changed? First one is solitary fibrous tumor uh, and hemangiopericytoma. These two were considered as diseases in one single spectrum, diseases of single spectrum coming under solitary fibrous tumors of dura. These are the lesions arising from fibroblasts and or in spectrum of solitary fibrous tumors of dura, because they share a common genomic inversion, that is 12q13 locus, resulting in fusion of NAB2 and STAT6 gene. Because as they share common genetic signature, these were grouped under single diagnosis, like solitary fibrous tumor slash hemangiopericytoma. Solitary fibrous tumor is low grade and hemangiopericytoma can be WHO grade 2 or 3. This is solitary fibrous tumor, very dark on T2, showing well defined CSF cleft surrounding the tumor, surrounding edema. And this is hemangiopericytoma. Second one is hemangiopericytoma going through the calvarium, presenting a scalp mass with rich vascularity, not definitely like spoke wheel or sunburst pattern of vascularity seen in meningioma. This show like more vascularity everywhere within the tumor. And close differential is meningioma. Then next is embryonal tumors. Embryonal tumors previously primitive neuroectodermal tumors. This term is no longer in use. Now all the tumors were now be referred individually by name. Those few of the tumors were genetically defined, few are not yet genetically defined. The genetically defined tumors include medulloblastoma, atypical teratoid rhabdoid tumor, and embryonal tumor with multi-layered rosettes with C19MC with a C19MC alteration. And not yet genetically defined include medulloepithelioma, CNS neuroblastoma, ganglioneuroblastoma, embryonal tumors not otherwise specified. All these are not yet genetically defined. Then coming to medulloblastoma classification. Previously, there is histological classification which we are all aware of, but now for the first time, molecular parameters, molecular classification based on genomic uh, genetic signature, medulloblastomas were classified into wingless, that is WNT activated, sonic hedgehog, SHH activated, non-wingless and non-sonic hedgehog, that is group 3 and group 4. Out of them, wingless is the least common and group 4 is the most common subtypes. Wingless most commonly seen in cerebellar peduncle and extending to sepia angle cistern. Sonic hedgehog seen in lateral cerebellar hemisphere or rostral cerebellar hemisphere. Group 3 and group 4, these are classically midline tumors extending to fourth ventricle, but any of the subtype, uh, any of these can be midline. We can see them in midline involving fourth ventricle. That is classic location of any type of medulloblastoma. Even wingless can be like can present like that. Sonic hedgehog can present like that. But if there is involvement of cerebellar peduncle, we can think of wingless type. If there is involvement of lateral cerebellar hemisphere with nodular enhancement, heterogeneous enhancement, we can think of sonic hedgehog. If there is involvement of vermis and extending to fourth ventricle, it can be any of these types. Group 3 carries worse prognosis seen in infants and children, whereas wingless carries best prognosis. Sonic hedgehog and group 4 carries intermediate prognosis. This is group 3 seen in infants and children, sonic hedgehog infants and adults, group 4 children and infants. Next, this is classic location of any type of medulloblastoma. First image shows midline mass extending to fourth ventricle, classic location for any type of medulloblastoma. Whereas second image shows lesion in cerebellar peduncle, classic of wingless. Third image, lateral cerebellar hemisphere, classic of sonic hedgehog. This is diffuse type. Fourth one, and these are the images. This is cerebellar peduncle, wingless, lateral cerebellar hemisphere with nodular heterogeneous enhancement with diffusion restriction. This is sonic hedgehog. This is midline involving fourth ventricle with intense post-contrast enhancement and drop metastasis. This is a C set of images is group 3, that is carries worse prognosis, and this is group 4, same as group 3, midline extending to fourth ventricle. But if we see these set of images, the last image shows enhancement is very less compared to group 3. That is group 4 show wisp like enhancement, whereas group 3 shows intense enhancement. Then coming to meningiomas. Meningiomas were previously classified as typical meningioma, atypical meningioma, and malignant meningiomas, but now these terms are not much in use. What we are going to use is WHO grading, meningioma grading like grade 1, grade 2, and grade 3. Grade 1 is definitely typical meningioma. Grade 2 and grade 3 indicates brain invasion. We cannot, it is difficult to determine meningioma grade based on imaging findings alone. Better not to give grading based on imaging findings, because most of the times when we give brain invasion, they turn out to be uh, typical meningiomas, that is without brain invasion negative. Most of the times they will come out like that. So, but we can suggest brain invasion uh, based on few features like effacement of CSF cleft, indistinct tumor margins with underlying brain parenchyma, enhancement of underlying brain parenchyma, and last one is low ADC values within the tumor. However, the most reliable feature is the presence of lower ADC value. Lower the ADC value, higher the cellularity of the tumor and higher the malignant behavior of the tumor. So peritumoral edema is not a predictor. It's not a predictor of atypical or anaplastic histology. So better not to predict grading based on edema of underlying brain parenchyma. So, better to rely on lower ADC values, loss of CSF cleft, partially effaced cleft, indistinct margins, but most reliable out of them is lower ADC value inside within the tumor. The next one is infiltrating glioma. This now all the tumors, all gliomas fell into two categories. One is astrocytoma, next one is oligodendroglioma. Because based on not only on their growth pattern or behavior, but they share genetic driver mutations, that is IDH mutations. Both astrocytoma and oligodendroglioma shows IDH mutation, IDH gene, mutation in IDH gene. These are homodimers. IDH1 and IDH2 are homodimers. Both of them show mutations in IDH gene. Diagnosis of oligodendroglioma. We have to give oligodendroglioma diagnosis only when it shows IDH mutation and 1p19q co-deletion. These are the two mutations oligodendroglioma should show. If there are no mutations, like if there is no IDH mutation, we cannot call it as oligodendroglioma. If there is no 1p19q co-deletion, we cannot call it as oligodendroglioma. Diagnosis of oligoastrocytoma previously we used to give mm, is now strongly discouraged because these are very rare tumors, very rare. Uh, when oligoastrocytoma not otherwise specified should be used only when testing for IDH mutation and 1p19q co-deletion is not possible or has failed. Very rarely tumors show both astrocytic and oligodendroglial genotypes, or mixed tumors are very rare. So oligoastrocytoma is usage of oligoastrocytoma is now strongly discouraged. Mm, For the WHO 2016 revision, IDH mutation has become definitional. It became definitional. IDH mutation became definitional for infiltrating gliomas. Mm, with 1p19q co-deletion further characterizing the type. So, IDH mutation is there means that is it can be astrocytoma or oligodendroglioma. If the tumor shows IDH mutation, it can be astrocytoma or oligodendroglioma. If the tumor show IDH mutation along with 1p19q co-deletion, we can categorize that tumor as oligodendroglioma. Without 1p19q co-deletion, we cannot categorize the tumor as oligodendroglioma. Then coming to astrocytoma, astrocytoma is an infiltrating glioma that is subdivided in the classification by the presence of IDH mutation. Astrocytomas may or may not possess IDH mutation. Few astrocytomas possess IDH mutation, few may not. But definitely they won't possess 1p19q co-deletion. If they are showing 1p19q co-deletion, definitely they should come under oligodendroglioma. Only tumor which possesses 1p19q co-deletion is oligodendroglioma. So, astrocytomas may or may not possess IDH mutation. The tumors which possess IDH mutation are considered as IDH mutant type, and those which won't show IDH mutation are considered as IDH wild type. Then, classification of astrocytomas: localized astrocytoma, diffuse astrocytic tumors. Localized astrocytomas, WHO grade 1 are pyelocystic astrocytoma and subependymal giant cell astrocytomas. These two are WHO grade 1. Pylomyxoid and pleomorphic xanthoastrocytomas are grade 2 astrocytomas. And then diffuse astrocytic tumors. Those are localized. These are diffuse astrocytic tumors, further classified as diffuse astrocytoma IDH mutant, diffuse astrocytoma IDH wild type. IDH wild, those astrocytomas which won't possess IDH mutation, their biological behavior simulates GBM even though their grade is less. Diffuse astrocytoma is grade 2, but if it is not showing IDH mutation, their behavior simulates GBM. Even if it is anaplastic astrocytoma, it is grade 3, but its behavior simulates GBM if it is not showing IDH mutation. Glioblastoma IDH mutant type and wild type were considered as grade 4, and diffuse midline gliomas H3K27 mutant were considered as grade 4. So, astrocytomas with mutations, IDH mutation carries better prognosis. Low grade astrocytomas with IDH mutation carries better prognosis compared to low grade astrocytomas without mutation. Coming to molecular markers which we need to remember. Those are IDH1 and 2, 1p19q co-deletion, ATORX, alpha thalassemia mental retardation X-linked gene, histone H3 mutant gliomas. All these molecular markers we have to remember. This needs a bit of mental gymnastics, so we'll go one by one. First one is IDH mutation. IDH 1 and 2 are homodimers. These are isocitrate dehydrogenase enzymes. These are 1 and 2 are homodimers. These are part of citric acid cycle. Isocitrate dehydrogenase converts isocitrate to alpha ketoglutarate. If there is mutation in IDH, isocitrate dehydrogenase, then there will be intermediate product that is called oncometabolite, which will be formed is 2-hydroxyglutarate. Instead of alpha ketoglutarate, we'll get 2-hydroxyglutarate. So this metabolite we can see in spectro. So IDH mutation uh, results in formation of 2-hydroxyglutarate metabolite. So, majority of diffuse astrocytomas and WHO grade 3 and grade 4 tumors with IDH mutation also show loss of ATRX. This gene, if there is IDH mutation, there will be ATRX loss also. As I have already mentioned, low-grade astrocytomas, that is diffuse astrocytomas and anaplastic astrocytomas which harbor IDH mutation slowly progresses to GBM, whereas those astrocytomas which won't possess IDH mutation or which won't show IDH mutation called IDH wild type, they super frequent, they rapidly degenerates to GBM and their biological behavior simulates GBM. There are differences in radiological appearance of IDH mutant GBM and wild type GBM. These are the differences. IDH mutant GBM will be bigger in size compared to wild type GBM, and the contours are ill defined in wild type with multilobar involvement and bilateral involvement common in wild type GBM, and it crosses midline. Wild type GBM crosses midline and it involves eloquent areas brainstem and diencephalon, whereas IDH mutant GBMs commonly seen in frontal lobe and which harbor TP53 mutation. They are common in, temporal and insular uh, temporoinsular lobes, and non-mutant TP53 non-mutant gliomas are common in frontal lobes, whereas MGMT methylated IDH mutant GBMs are common in left cerebral hemisphere and prognosis is better. Growth will be rapid in IDH wild type GBMs, and necrotic areas and percentage of necrosis will be higher in wild type GBMs, and enhancement will be heterogeneous and intense in wild type GBMs, whereas there is increased perfusion, low ADC, and there will be 2-hydroxyglutarate negative. They will be because they won't and they are IDH wild, that is no IDH mutation, so there is no oncometabolite 2-hydroxyglutarate, so 2Hg negative on spectro. And coming to 1p19q co-deletion uh, status of a glioma, if it is present, it is oligodendroglioma, so automatically prognosis will be better. Whereas IDH 1p19q co-deletion negative, that means it is not oligodendroglioma. Definitely this will be astrocytoma, whether it may possess IDH mutation or without mutation. Whatever astrocytoma, finally it degenerates to GBM. If it is IDH mutant, it will slowly progress to GBM. If it is wild type, it rapidly progresses to GBM. So prognosis is poor. And there is a relation between 1p19q co-deletion and ATRX. These are inversely related. If a tumor possesses 1p19q co-deletion, then ATRX will be intact, and vice versa. If the 1p19q is not deleted, that is 1p19q is intact, means ATRX there is loss of ATRX. That's all. Finally, this is summary of molecular markers for different types of gliomas. Oligodendroglioma possesses IDH mutation and 1p19q co-deletion. As it is co-deleted, so ATRX will be intact. Then coming to IDH mutant, diffuse astrocytoma and anaplastic astrocytoma, both show IDH mutation, and 1p19q will be intact because these are not oligodendrogliomas. Then ATRX will be lost. And IDH wild type diffuse astrocytoma and anaplastic astrocytomas, these are low grade, but their biological behavior simulates GBM. This diffuse astrocytomas, there will be 1p19q will be intact, ATRX will be lost, behaves like GBM, whereas anaplastic astrocytomas, same like wild type diffuse astrocytomas, but many of the times they show gliomatosis cerebri pattern. Anaplastic astrocytoma wild type usually show gliomatosis cerebri pattern. And finally, GBMs, as we have already discussed about differences between mutant GBM and wild GBM. Mutant GBMs, there is IDH mutation. 1p19q will be intact as this is not oligodendroglioma. And there is one particular thing, that is 1p19q is inversely related to ATRX. If this is intact, there will be loss of ATRX. So this is intact. ATRX will be last. Only tumor in which 1p19q will be deleted is oligodendroglioma, where ATRX will be intact. And IDH mutant GBMs most of the times are secondary GBMs, and IDH wild type GBMs are primary GBMs. Secondary GBMs are those GBMs which were degenerated from low grade astrocytomas, that is diffuse astrocytoma low grade with IDH mutation, and anaplastic astrocytoma with IDH mutant type, they degenerates to secondary GBM, IDH mutant GBMs. Next, I will see few images. This is oligodendroglioma, cortical based neoplasm with internal flare heterogeneity. This is a classic of oligodendroglioma, but we cannot give oligodendroglioma diagnosis imaging wise, but we can suggest oligodendroglial component within the lesion as per the imaging features. But we cannot give oligodendroglioma as diagnosis because 1p19q co-deletion is must for the diagnosis of oligodendroglioma. This is mismatch between T2 and flare. There is flare suppression within the tumor, cortical based tumor. There is this is triplet peak, and the last one with a spectroscopy showing triplet peak at 2.25 along with glutarate and glutamine and glutamate. So and 1p19q co-deletion is there, so final diagnosis is oligodendroglioma. Then this is a difference between IDH mutant and IDH wild type GBMs. This is lesion is large. This is smaller lesion showing enhancement is there but not much as seen in wild type GBM. ADC is low but not low as uh, wild type GBMs. As our first set of images are mutant GBM, second set, that is D, E, F and images are wild type images. So ADC very low ADC, intense enhancement and smaller lesion. This is bigger lesion, lower, that is ADC is bit higher compared to definitely this is lower but bit higher compared to wild type GBMs. Next, this is MRS showing 2-hydroxyglutarate peak along with glutamine and glutamate at 2.25 ppm, which is consistent with IDH mutation. This is gliomatosis cerebri pattern in diffuse astrocytoma, WHO grade 2. There is involvement of bilateral frontal right temporal lobes and bilateral median thalami. This is diffuse midline glioma. As majority of diffuse intrinsic pontine gliomas of pediatric age group harbor mutation at position K27 in the gene for histone H3, this subset has now been recognized as a specific tumor entity. The term diffuse midline glioma was given because these tumors do not exclusively occur in pons. They can involve any midline structure including thalami, cerebellum, spinal cord and other midline structures including third ventricle and pineal gland or hypothalamus. Then this is multinodular and vacuolating neuronal tumor of cerebrum. This is nodular appearance of the tumor seen in temporal lobe, posterior temporal lobe. Most common location is temporal lobe. And cortical based tumors show nodular, sometimes show nodular enhancement, appear like nodular tumors. So given name multinodular and vacuolating neuronal tumor of cerebrum. And this is diffuse leptomeningeal glioneuronal tumor mimics leptomeningeal enhancement in encephalitis, meningoencephalitis, tuberculous meningoencephalitis. And they show solid and cystic areas of enhancement along basal cisterns and similar appearance in spinal subarachnoid space also. And then relar fusion positive ependymomas. These constitutes approximately 70% of all childhood supratentorial tumors, and this mutation, that is relar fusion with C11 ORF95, will be absent in posterior fossa and spinal cord ependymomas. So this mutation will be seen only in supratentorial ependymomas. That's why it is considered as separate entity. That's why it is grouped separately. So this tumor will be large and show solid and cystic components with solid components showing diffusion restriction. It can be seen in children and adults. Then finally, a layered diagnosis of CNS tumors. We have now a layered diagnosis, that is integrated diagnosis. First, we have to get molecular information and WHO grading of the tumor and histological morphology of the tumor. After that only we can give final integrated diagnosis. As a radiologist, we can suggest oligodendroglial component within the tumor or astrocytomas like that we can suggest, but definite diagnosis is only after getting molecular information. So, for example, a tumor show IDH mutation and one P19Q co-deletion, then definitely that is oligodendroglioma. And WHO grading showed it is grade 3, that is there is no necrosis, there is no microvascular proliferation, so placed under WHO grade 3. And histological morphology showed chicken wire appearance and fried egg appearance. So it is under microscopy it is oligodendroglioma. Histological morphology also favors oligodendroglioma. So final diagnosis is anaplastic oligodendroglioma, like that. And this is my summary of additions, deletions, and changes. What got deleted? Gliomatosis, cerebri, now it is pattern, fibrillary astrocytoma, protoplasmic astrocytoma. We can forget those terms. Peanut also. Then coming to additions, diffuse midline glioma, as I have already described. All midline structures, it can involve any midline structure, not only pons. And ependymoma relar fusion, that is in supratentorial ependymoma, multinodular and vacuolated tumor of cerebrum, that is nodular appearance, most common in temporal lobe, diffuse leptomeningeal glioneuronal tumor near closest DD for meningoencephalitis, tuberculous meningoencephalitis, cystic and nodular enhancement along cisterns in spinal subarachnoid space, glioblastoma with primitive neuronal components. And what got changed? Hemangiopericytoma and solitary fibrous tumor, single spectrum of disease. And then brain invasion of meningioma, be guarded while giving the diagnosis. Then medulloblastoma, genomic subtypes. Then diffuse astrocytomas and embryonal tumor, that is medulloblastoma genomic subtypes and embryonal tumor, genetically defined, not yet genetically defined, all those tumors. Not no don't use a peanut. Then diffuse astrocytomas based on molecular markers. wild type and mutant type GBM differences, and that's it. These are my references.